2 years later, there's been a lot of progress, though none of these proposals have been taken to scale. Many hard questions remain, and we could spend a lot of time talking about the hard questions. How do you find people earlier before they feel sick? How do you ensure people get the information they need to make their own decisions? How can we improve retention and care? What treatment as prevention are best, and if we do it, and if we do even more circumcision, will it really lead people to give up less costly and proven effective ways of prevention that they were previously observing? All these questions are important, but should any of them be a bar to doing what we know we have to do? I would argue no. I remember well back in 2003 when Jim Kim launched the 3x5 initiative. There were lots of serious questions about whether we could meet the goals of increased treatment. There were people who even said, since we can't treat everybody who needs it, how will we decide who gets it and who doesn't? And wouldn't we be better off, because it's so much cheaper, just doing universal prevention efforts? But guess what? We responded to Jim Kim's challenge, and now there are 8 million people on treatment. That's the way we have to respond to these challenges. Sometimes you have to make a commitment before you know how you're going to get there. China, Rwanda, and Swaziland have all announced their intent to implement treatment as prevention at scale. We are working with the government of Swaziland and our foundation. The prevalence is about 26%. I've been really impressed by the leadership and foresight there. They know this is the only way they're going to achieve their goals, and they're focused, therefore, on how to do it, not whether to do it. Malawi is a country with very severe resource constraints, where I also have the honor of doing a lot of economic work. They made the decision to put all pregnant women on treatment immediately for life. They didn't wait to figure out how to do it or how they were going to pay for it. They made a commitment, and I believe President Manda showed wisdom and strength in doing it, and we should all be grateful to her, because now every one of you can say, if Malawi isn't waiting, how can the rest of us wait? You may think this is naive, but I've seen it happen over and over again. This is one of those, if we build it, they will come. If you scale it up and it works, the money will be there to fund it. We also talked to Dan a lot about improving treatment that works, identifying the patients earlier, reaching them where they live, treating diseases that really kill people like TB and cryptococcal meningitis. Today we know about the best practices from groups like Partners in Health, Mothers to Mothers, and MSF. We know about the importance of decentralizing services, empowering community members. We know from pilots in Mozambique, Malawi, and Zimbabwe that if we provide CD4 testing at the point of care, we can cut pre-ART loss to follow-up in half. We know that if nurses play a larger role in caring for patients, including initiating treatment, we'll reach more people in an environment where they feel better understood and cared for. So when we scale up, we will stop just paying lip service to community engagement, and we'll have to start engaging and relying on communities. These are things that I believe. I think the money will be there if we prove that we're responsible with the money we've got, and if we prove that these approaches work. You have nowhere near tapped the universe of people who will invest in meeting these 2015 goals and creating an AIDS-free generation. We just have to keep pushing the rocks up the hill. Speaking of rocks up the hill, since we're in our nation's capital, where the prevalence among some groups is as high as it is in countries in Southern Africa, I'd like to just say a couple of words about that. We have about 1.2 million people in America living with HIV. Barely more than a quarter of them are getting optimum care. Infection rates are rising among young gay men and exploding among young black gay men. Latinos, Native Americans, Asian Americans, and Pacific Islanders, you saw some of them go by, many of them feel that because of the overall progress made in the fight against AIDS, they're just going to be left out and left behind. But in this city, government and community leadership has been reinvigorated around community viral load testing and test and treat strategies. They are making a difference. Since 2007, there has been a threefold increase in the number of people being tested every year, a tenfold increase in the number of condoms being distributed every year, 300,000 clean needles provided every year, and 90% of the people who test HIV positive in Washington, D.C. see a doctor within 3 days. Was the first to develop a comprehensive strategy for the domestic epidemic. The Affordable Care Act, which, thank God, the Supreme Court upheld, will provide coverage. The funding that he and Secretary Sebelius committed this week to close the ADAP waiting list is very important. And I want to just emphasize something else that in the context of the United States can be huge. You all know that when I do proxy work around the world, when our foundation does, we use generic drugs. And they've made a huge difference. And PEPFAR money can now be used to buy those drugs. First, because Eric Goolsbee and all the people at PEPFAR agreed that they should. And second, because I made an agreement with President Bush when he was in office that I would submit all of the medicine we sent anywhere in the world to the FDA. And he said if the FDA approved them as being effective and appropriate, that any local country could use their money from PEPFAR to buy that medicine. And he kept his word. And that was the beginning of this. And I'm very, very grateful for that. But that means that in America, where these drugs are not available, we got to do something for people without insurance who can't afford the drugs. Our foundation has partnered with HarborPath, NASDAQ, and major pharmaceutical companies to make access to affordable HIV medications available faster, in a simpler way, on a longer-term basis for people who don't qualify for ADAP but can't afford the drugs. Here's the idea. HarborPath will provide a one-stop shop for uninsured patients to access all the patient assistance programs available. The program will simplify the paperwork and cut through red tape. And I want to thank ViiV Pharmaceuticals and Merck, who have already stepped up to support HarborPath with steeply discounted medicines, and I hope all other manufacturers of HIV medications will soon follow suit. The United States. Besides D.C., the next biggest problem we have with AIDS is in the American South, where I'm sad to say, since it's my home region, there's still too much stigma. Stigma against men who have sex with men, against sex workers, against people who are drug users, where this is not treated enough as a public health problem. And that, plus the poverty, plus the disproportionately high percentage of people in our country in the South who live in rural areas and therefore have some of the same exact access problems that people in Africa and Southeast Asia and other places have. That created a big problem for us. I just wanted to say two things. It's embarrassing to me to think that stigma against people with HIV exists anywhere in America. It's still a problem in other places around the world. But look at the numbers that came out just this week. Yes, it's true that 56% of the people that need medicine now to stay alive are getting it. But look at the numbers in the area where there's more stigma. Central and Eastern Europe, way less than that. In the Middle East and North Africa, even less than that. Not even 25% in the latter, barely a third in the former. So we, all of us, can't be blind to the fact that no matter how much we come together and cheer each other and see the evidence, that we still have to fight stigma wherever we find it and support our friends and neighbors who are doing that. And we also have to deal with the fact that not everybody treats these drug problems the way Washington, D.C. and a lot of nations do as a public health issue. The great Dr. Matilda Krim and Ethan Nadelman had an amazing article just a couple of days ago documenting the death rate from AIDS that has come as a direct consequence of the refusal to see drug-related infections as a public health problem as opposed to a criminal justice problem. I think, for me anyway, thinking about where we were in 2002 when Nelson Mandela and I went to the AIDS conference in Barcelona, and we were literally rattling a tin cup for money. By the way, I just was with him on his 94th birthday, and I told him I was coming here, and he said, "I am retired, but tell them I wish them well." I think you should be excited about this. I know you're worried about the money and a bunch of this other stuff. You should be really excited about this moment because you're committed to work through the financial crisis, to go beyond incrementalism, to embrace profoundly ambitious goals for 2015. I've been asked actually to work, thanks to the AIDS Life group in Austria with a couple of African countries, to figure out how you actually would take mother-to-child transmission to zero. Because they know it's way more than just getting the medicine out there. But it's exciting. And we will do well as long as we refuse to let what we don't have slow us down. We have to use what we do have to get the programs off the ground, and we'll answer the questions as we go along. We've got stronger leadership from every sector than I can remember. The research community is still laboring away toward the dreams of a vaccine and a cure. More and more people from the private sector bringing their business acumen to the financial questions. Civil society still pushing us all to do the right thing. Communities in America, from Anacostia and Oakland to Mumbai and Sao Paulo to St. Petersburg and Kiev to Lilongwe and Kigali. All of them taking responsibility for their children and their future. They have not gotten enough credit. The developing world and the middle-income countries for spending even more money than the donor countries and the individuals are doing to fight this epidemic. They are worth our support if they are coming up with this money. We've also got a lot of policymakers who seem committed to keep working on this, if necessary, until everybody in this room is as old and gray as I already am. If that's what it takes. This is serious. I've been doing this a long time. All this has really happened because of you and the people who sat in these chairs at every previous AIDS conference, going back to the beginning. Millions of people in an AIDS-free generation still depend on your daily tenacity and courage. No, we don't have all the money or all the answers we need, but we have you. We have you to thank for the progress that's been made, and you to make us believe we can achieve an AIDS-free generation. And all over the world and places where we work, we have millions of people nourishing their dreams and their children's dreams instead of giving up. It's worth a lot. We have to deliver for them. Thank you, good luck, and God bless you.